In this unit, we're going to continue learning about the pulmonary rehabilitation program. Today, we're going to talk about the psychosocial aspects that the COPD patients have to deal with due to their disability from their inability to breathe properly. So, the overall goal of the pulmonary rehabilitation is to improve the quality of patients' lives. Physical reconditioning alone is not sufficient, and we talked about physical reconditioning in our last unit. So psychosocial indicators generally are better predictors of both the frequency and length of COPD patients' rehospitalization than are traditional measures of pulmonary function. These patients are short of breath, they're having trouble breathing just to do everyday functions, just to go to the grocery store or to walk to the bathroom. So the whole psychosocial thing becomes kind of impairing for the patient. They feel worthless. They feel like if I can't do anything, why live? So it's important that they get the proper support to kind of encourage them to be more motivated to do other things. Studies show that the relative success of reconditioning plays less of a role in determining whether patients or complete a program than does meeting their social needs. And like I was saying in the last slide, these patients with COPD, they lose their motivation. They don't like depending on other people, and sometimes they have to because they can't get around and do the things they used to do. So COPD can negatively affect patients' overall outlook and reduce motivation. It takes a lot to get them to do anything anymore because anything they do as far as exertion, they're extremely short of breath. Patients with COPD often have anxiety and stress. They get frustrated really easy because everything they do causes them to be short of breath. So psychosocial support in combination with physical reconditioning is needed to cause the best possible outcome. The progressive nature of COPD can negatively affect patients' overall outlook on their disease and reduce their motivation to adapt to its consequences. A lot of times when you take care of these patients in the hospital, it's very hard to get them to do anything, the breathing exercises, even just to walk the hallways because everything they do just makes them winded and short of breath. It takes a lot of energy just to breathe. Just sitting at rest sometimes is a struggle for these patients. So they tend to struggle with emotional problems, are not unique to these patients with chronic lung disease. As a result of it, they're very hostile sometimes. They're very depressed. They have to have psych get involved and get them on medications to help reduce their anxiety because they're in a chronic disease state. In regard to the social needs of patients with COPD, common observation is that patients spontaneously receive support and encouragement by simple association with each other. An example of that will be the Better Breathers Club. It's a chance for patients with the same conditions to come together and to kind of support each other mentally, talk about their struggles and the things that they go through, maybe even give suggestions to each other to have them have a better quality of life, what they do to make it work for themselves at home. Recent studies indicate that patients that lack a strong social support structure are at higher risk for rehospitalization than those with such networks. So some patients, they don't always have the family support at home. They don't always have the availability of doctor's care. So these patients very recurrently go back to the hospital because it's what's familiar and what's easy. They don't have to worry about being alone or scared and things like that because they have hospital workers there to take care of them. So a well-designed pulmonary rehabilitation program should take advantage of this knowledge and address the social support needed for these type of patients to participate in. So as we continue to think about the social function, the social aspect of the patients that have lung disease, it's the physiological impairment of patients with chronic lung disease in combination with other variables can strictly restrict a patient's ability to perform routine tasks requiring physical exertion. Any little thing these patients do just to walk to the mailbox is a chore. So intolerance for physical activity lessens the patient's social activity. They can't go out and do as much. They don't like going out, hanging out with their friends because they may have to have an oxygen tank. They may be embarrassed about it, or they just walk a little bit and are short of breath. I can remember a family member of mine that went on a trip with someone who had lung disease, and they couldn't even walk through the airport. They had to be wheeled through the airport, and that can be embarrassing for the patients. So sometimes they tend to not go out and do things just because they don't want to seem like they're less of anyone else as far as being able to do things. So more importantly is the patient's loss of confidence and their ability to care for themselves, and the reluctant loss of feeling of dignity and self-worth. So some common goals for the pulmonary rehabilitation programs are as followed. We want to control the infection. We want to take care of the basic airway management. We want to improve the ventilation and cardiac status, improvement in ambulation and other types of physical activity, reduction in overall medical costs, reduction in hospitalization, the psychosocial support, occupational retraining and placement when and where possible, family education, counseling and support, and patient education, counseling and support. And of course, again, and this is so important, that's why they reiterate it twice, and that's the control of respiratory infections. Because if they have an infection, they're down for the count for at least a week or so, and everything is pretty much have to start over because they get so weak. So we've talked about the psychosocial aspect of pulmonary rehab. We've talked about reconditioning. And so we have a patient now that's in the actual program. So when they get into the program, we have to come up with objectives and goals and things that the patient should be working towards. So what we do in a pulmonary program is we want to develop a diaphragmatic breathing skills, development of stress management and relaxation techniques, which we've kind of learned about in the last unit, involvement in a daily physical exercise regimen to condition both skeletal and respiratory related muscles. You want to make them strong physically. Adhere to proper hygiene, diet, and nutrition. They have to have good hygiene, diet to have more energy, and nutrition as well. Smoking cessation, if applicable. A lot of these patients you will find are ex-smokers. Some of them do continue to smoke just because they like it. Even if we find that they are still smoking, you want to encourage them to stop because it's always better that they quit. Proper use of medications, O2 and breathing equipment if applicable. Most of these patients you'll find are on some type of medication, and some of them even use oxygen. And you find that even after they go through pulmonary rehab, they're able to even get off of the oxygen because they're stronger. Application of airway clearance techniques when indicated. Focus on group support because they have to have support to be encouraged and feel like they can do it and be motivated. And provisions for individual and family counseling. So we've talked about the goals and objectives. We talk about the psychosocial aspect of things. So once the patient actually is enrolled in the pulmonary rehab program, what is the evaluation criteria so we can better decide what the care plan is? So the patient evaluation begins with a complete patient history. So you want to check out the medical, the psychological, the vocational, and the social, as well as design patient questionnaires and interview form, which will help with this next step. So you're going to complete a physical examination. We always want to examine our patient to make sure we kind of look at everything. So we want to do a chest x-ray, CBC, get an EKG, check out the serum electrolytes, and urine analysis may be needed. You'll find a lot of patients are confused and have weakness as a result of just a plain UTI, urine tract infection. It really affects the elderly quite a bit. So you also want to do evaluation and do arterial blood gas, and then pulmonary function testing and exercise evaluation are often needed. Just depends on the situation with the patient. So when we're looking at tests and evaluations, we want to determine the patient's cardiopulmonary status and exercise capacity, which includes both pulmonary function testing and cardiopulmonary exercise evaluation should be both performed. So the pulmonary function testing should include ventilation assessment, lung volume measurement, diffusing capacity, and pre and post bronchodilator spirometry. This helps us to see exactly how compromised the patient's lungs are, because we don't want to push them too hard when we're doing the program. We want to kind of make sure that we're pacing ourselves and moving at a pace that's proper for the patient. The cardiopulmonary exercise evaluation serves two purposes in the cardiopulmonary rehabilitation program. It quantifies the patient's initial exercise capacity, it helps set a target heart rate, and provides the basis for exercise prescription. It yields the baseline data for assessing progression over time. So we kind of want to see where the patient is now, and then we can kind of see how they've progressed over time, and even towards the end of the program, how far they've come. So in addition to the cardiopulmonary exercise evaluation, we have to also help determine the degree of hypoxemia or desaturation that can occur with exercise. So we have to provide an objective basis for titrating O2 therapy during the exercise program. So some patients with exertion, their oxygen levels tend to drop. And you have some patients that rest, their levels tend to drop. So we have to kind of evaluate all aspects to see, do we need to give them oxygen during their exercise program, or are they okay to exercise without it? The actual exercise evaluation procedure involves serial or continuous measurements of several psychologic parameters during graded levels of exercise on either an ergometer, or a treadmill. Remember, we talked about graded levels of dyspnea, how we evaluate that in our last unit. So the graded levels are spaced at 3-minute intervals, and work levels are increased progressively until the patient cannot tolerate a higher level or abnormal hazardous response occurs. So you kind of do the exercise for several minutes, and then you have them grade and give them on a scale of 1 to 5 or 1 to 10, whichever evaluation tool you're using to see what's their level of dyspnea and whether or not we've pushed them to the point of fatigue. The next test that we would do is arterial blood gas analysis. Arterial oxygen, PaO2, and saturation, SaO2, should be measured at rest and at peak exercise. Pulse oximetry may be used to warn the Rspt of desaturation events during exercise and assess the patient's response to supplemental oxygen during exercise. The first indicator that the patient's having trouble is usually by their pulse ox readings. So in your book, on page 1270, table 55-1, are some guidelines given by the AARC for indications to exercise testing. So some of those indications are the following: the need to assess and quantify arterial oxyhemoglobin levels during exercise in patients with suspected desaturation, the need to quantify the response to therapeutic intervention, the need to titrate the optimal level of O2 therapy during activity, the need for preoperative assessment for lung resection or transplant, the need to assess the degree of impairment for disability evaluation. Also on that chart are the listings of relative contraindications to exercise testing according to the AARC guidelines. So when we say relative contraindications, referring to patients who cannot and will not perform the test, and that's due to a number of factors. These factors include the following: those with severe pulmonary hypertension or cor pulmonale, known electrolyte disturbances, for example, hypokalemia, hypomagnesium, resting diastolic blood pressure, that's the number that's the bottom of the blood pressure reading, so a BP greater than 110 millimeters of mercury, or resting systolic blood pressure of greater than 200 millimeters of mercury. Those with neuromuscular and musculoskeletal and rheumatoid disease exacerbated by exercise, those with untreated or unstable asthma, those with uncontrolled metabolic diseases, and those with a SaO2 or SpO2 less than 85 on room air. This slide kind of lists the different indications, contraindications, precautions, and possible complications that come from exercise testing for evaluation of hypoxemia, desaturation, and or both. This slide just lists the assessment of need and monitoring that's necessary for exercise testing and evaluation. We're going to go more into this in the next couple slides. Common physiologic parameters measured during exercise evaluation are as follows: blood pressure, you want to make sure the blood pressure is not getting too high. Heart rate, too high or too low is not a good sign. Their EKG or ECG. Respiratory rate, we don't want them to overexert themselves or breathe too fast. We want to monitor their arterial blood gases, oxygen saturation, maximum ventilation, O2 consumption when it comes to the energy that they're using, CO2 production. They can either blow off too much CO2 or they can be breathing ineffectively, and their CO2 will continue to rise and become acidic, and that can be a problem. Respiratory quotient and O2 pulse, which also deals with the heart rate. Here are some more indications for pulmonary rehabilitation. Now remember, we're referring to what is considered the AARC guidelines for indications for pulmonary rehabilitation. So that includes dyspnea during rest or exertion, hypoxemia or hyperkalemia, reduced exercise tolerance, unexpected deterioration or worsening of symptoms against a background of chronic dyspnea, and reduced but stable exercise tolerance, need for surgical intervention, chronic respiratory failure, ventilator dependence, and increasing need for acute care intervention, for example, ER visits, hospitalizations, and unscheduled office visits. Contraindications to pulmonary rehabilitation according to the AARC guidelines. That means we're not going to do pulmonary rehabilitation for these patients with these factors. And these factors include the following: ischemic cardiac disease, acute cor pulmonale, severe pulmonary hypertension, significant hepatic dysfunction, metastatic cancer, renal failure, severe cognitive deficiency, psychiatric disease affecting memory and compliance, substance abuse without the desire to cease use of substance, physical limitations, which include the following: poor eyesight, impaired hearing, speech impediment, or orthopedic impairment. Anytime we're doing pulmonary rehabilitation, we always have to think safety first. Because these patients have impaired lung capacity and they're very short of breath very easily, it doesn't take much for their saturation levels to drop or their heart rate to speed up or to go down. So we always have to have precautions in place just in case the patient goes sideways and maybe even cardiac arrest. So the following safety measures should be implemented to minimize risk during exercise evaluation. Patients should undergo a physical examination, including a resting ECG. A qualified physician should be present throughout the entire test. Emergency resuscitation equipment must be readily available for the just in case. And staff conducting and assisting with the procedure should be certified in BLS and ACLS in case the unfortunate thing happens, they stop breathing or their heart stop. And tests should be terminated promptly if anything indicates that the patient is not doing well. You should stop the test immediately. Patients and clients most likely to benefit from pulmonary rehabilitation program are those with persistent symptoms of COPD. So they're always short of breath, always having anxiety, they're depressed, any little thing, they're just not motivated to do anything because they just don't have any energy. So these patients, they tend to go into the program, they get better, they're stronger, and they have the most benefit from the program. But patients and clients should be ex-smokers, ideally. Most of them are, but there are some patients that continue to smoke regardless of being involved in the program. So we always encourage them to stop smoking and refer them to a smoking cessation program prior to the start of pulmonary rehabilitation program if they're willing and agreeable. Patients or candidates that are considered inclusion for the pulmonary rehabilitation program generally fall into one of the following groups. That's patients experience respiratory limitation to exercise, resulting in termination at a level less than 75% of their predicted maximum oxygen consumption. The second reason will be patients and clients that have significant irreversible airway obstruction, meaning their FV1 is less than 2.1 or FEV1% is less than 60% of predicted. Patients or clients that have significant restrictive lung disease, meaning their total lung capacity is less than 80% of their predicted, and the DLCO is less than 80% of predicted. You're going to learn a lot about all that in your pulmonary function class next semester. And then patients or clients with pulmonary vascular disease, meaning their DLCO is less than 80% of predicted. Exercise is limited to less than 75% of maximum predicted oxygen consumption. Patients that will be considered total exclusion for the pulmonary rehabilitation program will fall under the following: cardiovascular instability requiring cardiac monitoring, malignant neoplasma involving the respiratory system, and severe arthritis or neuromuscular defects. When the patients come to pulmonary rehab, they usually do it in groups. It's not usually an individual type of program. They're usually there together. It's a social thing. Patients enjoy coming to pulmonary rehab because they get a chance to meet new people, have new friends, and they're around people that understand their physical disabilities because they're also having the same trouble. So when we're placing patients into groups for their classes, they're usually in classes where it's just all males or all females, and they're grouped together on the basis of severity and overall ability. Here are a list of some more indications, contraindications for pulmonary rehabilitation. And it deals with the symptomatic patients with COPD. Usually go stage 3, which means severe, and stage 4, which is very severe, and stage 2, which is moderate, may also be considered. Patients with bronchial asthma or associated bronchitis or asthmatic bronchitis. Patients with combined obstructive and restrictive ventilatory defects. Patients with chronic mucociliary clearance problems, and patients with exercise limitations because of severe dyspnea. Contraindications, some more of them. Cardiovascular instability requiring cardiac monitoring. Consider cardiac rehabilitation because that is another program outside of pulmonary rehabilitation. Malignant neoplasma, which you've already said, involving the respiratory system. Severe arthritis, neuromuscular abnormalities. A relative contraindication, refer to physical therapy for case-by-case review. This is the end of Unit 1C.